So let me just start by asking the first question. Can you just share a little bit about the work that you do, and what brought you to do that work?
Sure, sure. Well, hello, I'm Charlene Green. I'm the Assistant Dean of Admissions, Outreach, and Medical Pathways at UC Davis School of Medicine, located in Sacramento, California, the northern area of California. Um, I have been here at UC Davis Health for now 15 years, and at the School of Medicine, 13 of those 15 years. Since being here, I actually came in as a mental health provider. So I really came here to provide academic wellness and career support to medical students. And then very quickly found I had a passion for kind of assessing gaps in student development areas and student affairs areas. And it kind of has led me to other work around equity, inclusion, belonging, learning climate, policy work, and then eventually to admissions and all of our outreach programs here at the School of Medicine. So that's kind of how I got started and just kind of have been collecting jobs along the way. So now I lead roughly 4 teams, all focused on kind of student affairs, admissions, and pathway work, and then get to work on several national work groups and projects related to just admissions and access to health professions.
So you went in as a clinician, and now you focus more on as an administrator.
Yes, definitely. My role is very administrative right now. I always tell people I'm a PsyD in MD world, which might sound funny to some folks, but really, I think the mental health aspect has really helped me navigate through many facets of the medical environment, the clinical environment, and medical administration as well.
Is there a natural dissonance between between a provider priorities within an institution versus an administrator priorities? Like what are some of the common tensions as far as what a provider or clinician might be inclined to focus on for an institution versus your role as
Sure.
an administrator?
Yeah, 100%. I think having both perspectives has helped me do my job well. So really having the perspective on what health profession students and patients go through, because I was a clinical social worker prior to
Mm,
becoming to the school, before coming to the School of Medicine.
yeah.
Having that perspective on, again, the patient, where it's patient centered, the clinical environment, but also students as patrons and consumers of services. I think that perspective has really helped me be a better advocate at the administrative level, right? So if I'm understanding kind of what patients and students are going through, then it helps me kind of get that perspective and, write policy that is inclusive of their perspective, what their specific barriers might be, that is keeps them at the forefront of inclusivity rather than being exclusive,
Mm.
where they don't have that voice and level to level set at that.
Yeah, well, and I'm wondering if something similar where somebody who has been a clinician and has had a health profession pipeline of that novel sort, run an organization or an institution full of educators and educating those trainees. So
Yeah, well, I think we
yeah.
could say that about pretty much any profession. If you think about someone who, is leading a car mechanic shop, right? If you've never fixed a car before, it's going to be really hard for you to hold folks accountable for what their scope is. It's going to be hard for you to understand what they do. It's going to be hard for you to fill in when they're not available. So there are definitely pros and cons to, I say, growing up in an institution, right? I've been here obviously 15 years, clearly very young still. And so, I've pretty much grown up here professionally. And so, of course, there are lots and lots of pluses. Like I know the system, I know the culture.
Mhm.
It's helped me be a faster, more effective leader for sure. And again, I have that perspective of all of these different patrons, different stakeholders, different collaborators to kind of bring that lens to how we make decisions for, the broader institution. And of course, the cons that come with that is, sometimes you can get, like I said, I've been collecting jobs along the way. I haven't really got to let go of any jobs yet. But luckily, I really do love everything that I do. But it can be sometimes very hard to separate yourself from past roles, or sometimes when you're moving from peer to then a leadership position, sometimes that dynamic can be a little bit difficult. So really, that relationship building piece, you can't get so busy that you forget about the relationship building piece with your
Mhm.
team and staff, right? If your team doesn't believe in your vision and how you want to accomplish like strategic plans and the goals of the institution, then it makes it really difficult to accomplish that work.
Well said. Okay, so I want to ask, I want to now we got a little bit about you. I want to start to step out just a little bit. This particular episode of the series we'll focus a little bit more on one specific area of social mission. As mentioned, social mission has five main domains: socially accountable leadership, commitment to community, equitable expansion of the health workforce, transformative curriculum and programming, and supportive school ecosystems. And a lot of the work around admissions, where we know that UC Davis is quite literally the champion when it comes to admissions, as far as in medical education. You're the North Star that we look to. UC Davis has come up twice today in conversations that I'll mention
In a good way.
in good ways, as you might imagine. But with that being said, I'm curious to know a little bit. I kind of want to dive in a little bit from, if you put on your hat, both as somebody who is an administrator, who supports innovative ways for health profession schools admissions, but also just more broadly too. So just kind of coming from that angle. From your perspective, what are one or two of the most significant gaps that you see in terms of having in terms of how admissions should be run in the United States across health professions?
Yeah, I have 2 points on that are kind of intertwined, actually. So I would say this would be we need to run admissions for whatever the goal of the community is, right? So admissions should really be focused on, again, we look at data. So we're looking at areas that have the highest health disparities. Those are going to be our areas of focus for outreach, for programming, and for admissions, because we have this social mission, right? So we
Mhm.
want to fulfill the needs of society and the communities that we prioritize, right? So that's one. A big gap, I think, between what that pool looks like and what education looks like. Oftentimes, because many medical schools across the country, medical school is admissions is very competitive, right? So it's a highly metric driven process for the most part across the
Yeah.
country. Right. And so, yes, it is. If it was easy, everyone would do it. Right. So you do have to have the academic knowledge and really the discipline in rigor to be able to do medical school. Right. But after you can do kind of like the academic piece of it, there's a really a much larger piece, right, that everybody can't do. There's just some things you can't learn in a book. Right. So when we think about, for instance, where training takes place, much of the training for medical students takes place in like these larger hospital systems. And what's absent from that really is like, the federally qualified health centers, community health clinics, our tribal health centers. So again, our job as healthcare providers is to take care of everyone. And I don't know, I think there's sometimes a disconnect between the education that's available to health professions students and the needs of the community, right? When we think about who needs care and who's not getting care, right? Who needs help, there is definitely a gap in what's available within health professions education. So that's the first thing. The second thing, again, very intertwined, is that learners have a like limited longitudinal exposure to other facets that really affect healthcare, like poverty, racism, immigration status, disability, housing insecurity. Like these things are actually at the foundation of if a person has the ability to be able to get well, to be able to maintain their health, their care, to be adherent to treatment plans. All of those things are very intertwined. And so again, there's kind of a disconnect with learners being able to get specific longitudinal training with those facets incorporated into the training, which we know that these are elements that patients face daily, every minute, every hour, right? So there is definitely a disconnect in the knowledge, I think, being provided in medical education.
Interesting. What do you think is I guess going back a little bit more to the first point, more so than your second point, what do you think is the reason for the misconception? I want to call it, saying misconception is a bit of a leading question. So let me pause there. What do you think is the reason for the perception that admissions practices that are conscious of, yes, we know that you've met this minimum threshold. Now let's consider these other components of you as a person in your journey. Why do you think there's a perception that exists at all that in some way runs counter to a meritocracy?
I think that when we talk about these things that directly shape the outcome of patient health and patient care, I think one of the issues really is we're looking at cultural competency or cultural humility as like a value add. Like, okay, this is great that they have it, but really it's a necessity. I think that's the challenge, is that admissions are not really putting enough weight on the lived experience that certain learners bring to spaces that, again, folks who come from, underserved areas, marginalized communities, they often have experience of, again, very, very diverse backgrounds, right? And so I don't think there's enough weight being put on how much those lived experiences account for. And even, yes, they understand various populations of patients, but it's also about a level of perseverance, resiliency. Not that we want learners to suffer and they need to be tough to get through the process, which they do, but that's really not the exact reason. It's that medicine is hard. You will lose patients. You will see very sick children. You will deal with difficult things. So someone who's got it right their whole life and have had no missteps, and everything's kind of been handed to them, and they have the academic, knowledge to get through medical school, doesn't mean they have the emotional intelligence and the worldliness to be able to focus on patients with these vast amount of different issues, right? It takes a lot of emotional intelligence actually to be in the clinical environment, and it's to see it as a privilege and not a paycheck is something that everyone doesn't come into the healthcare environment with.
Well said. Well said. I do think that there's a difference between those who see this as a privilege versus a paycheck, and the reasons for the calling. That's an interesting point. I'm curious to know if there were any if there's a message that you could deliver to the broader network of educators, administrators, and learners within the broader social mission network. What might that be? Like, what's something that you feel as though, hey, we really got to be paying attention to this thing, or this is something that's like people should know this. People should know X. And you can speak to any one of those three audiences or all three.
Yeah, I think mostly speaking to students who are pre-health professional, like wanting to go to health professional school. I think make sure you're doing this for the right reasons, for your own mental health and wellness. This career, again, can be very difficult. You will have challenging times. Mistakes will be made. You will have times where there will be patients that might not want to see you because of whatever identity you have, and there'll be times that mess with your spirit, your ego, that mess with your confidence. So you have to make sure you're in this for the right reasons if you're going to do this 10, 20, 30, 40 years, because it's not sustainable to do something that you don't enjoy. So make sure whatever that reason is for you, make sure it is related to the community, your life's work, access and equity. Like, make sure you always have that motivation in mind. And then what I will say for administrators and faculty, again, the road is not easily traveled to a healthcare and health profession school. So really humbling ourselves to think about what it was like when we were on that pathway. I think sometimes we forget how difficult and what the pressure is like. And I think also sometimes we're very focused on, if I was able to get through this really difficult thing, these learners, they're too soft. They're not getting through. They should be able to do this. I had way worse. Okay, we're in different times. Evolve from that. Evolve from that, because what we're doing is we're turning away really amazing learners that have those perspectives but may need a little bit more build up in professional identity, need to be able to see themselves in these spaces so they can better take care of patients, because we're really losing out on some amazing, amazing future providers, because we can be very discouraging because we want people to do things in the way that we did them. So evolve from your mindset, meet people where they're at, and try to really think about how you can contribute and not subtract from the future healthcare workforce.
Um, I think that that's a really that's a really good point. Nothing is more frustrating to me personally than this idea of, well, the reason we do it this way is because we've always done it this way. And sometimes you're so intrinsically linked to the way in which the ways that of knowing that you came about, that we don't have we sometimes have a tendency to think, well, this is what I went through it, therefore X should be able to go
Be
through it
fine.
too. And the call to action to evolve for administrators and faculty, decision makers within schools to move past that thinking because times have changed and transformation requires evolution, I think is a really important one. Yeah. Um, I'm curious to know about if there is anything that specifically brought you into, I mean, as you kind of started off, you sort of jumped into like, your role. Um, is there anything that, sort of groundswell, like a groundswell of life experience or anything in particular that sort of put you on the trajectory to where you even got to that point?
Yeah, definitely. Well, my life's work has been education equity in a general sense. I am a, community college grad. I went to a state university. I come from, South Stockton, California, once the murder capital of California, pretty rough place. Um, so I had no dreams and aspirations really for myself because I just didn't know of any. I just really couldn't see it for myself. My mom got through fourth grade. My dad graduated high school. So I never thought I would even be someone who would have, multiple degrees and advanced degrees. These people are trusting me to run a medical school. Like, that's crazy, right? So, um, so I think I wanted to help other students who maybe didn't know the way or couldn't see a future. And we know that education equals access, right? Education
Mhm.
equals finance, money, opportunities. And so we know that that opens doors. So that's kind of been my life's work. I think some defining moments for me in life. My dad's family had six siblings, three brothers, three sisters. All three of the brothers passed away from complications with diabetes and had just different comorbidities at a very young age, like in their 50s. So that was always in the back of my mind about just health in our community, especially lots of stigmas within Black men in community and trust for the healthcare. So that was definitely some defining moments in my life where I knew that healthcare was going to be a focus for me. And then I think in hindsight, one of the defining moments that always come up for me is now being at the medical school for 13 years. I am visiting the babies of my students. I've officiated weddings of my
Oh,
students. I still have students who are, they were former students who are attendings now that still text me Happy Mother's Day every year. I'm seeing my students turn into community leaders, politicians, hospital leadership, faculty members. And it really brings me back to the concept of number one, I'm just so proud of the physicians that I've built because they are absolutely fulfilling that social mission. They are going out and advocating at the patient level, at the institutional level, and also at the state and even nationally. So it's been amazing to see the growth of my former students and the physicians we built here at UC Davis School of Medicine, and they're just really incredible people. So for me, it helps me stay motivated to keep doing the work that I'm doing because I know, seeing kind of like, the fruits of your labor as like a mother, an auntie, a big sister, that part has been really incredible for me. I have this book when I get overwhelmed. I have this book with all of my students, like cards and letters and emails that I print out, and I call it the You Don't Suck book. So when I feel bad, I go in this book and just read all of the kind words that my students have written to me. And it just fills up my cup and reminds me of the incredible work that we're doing with building physicians that our communities need. They are back in their communities doing what they said they were going to do. So it's really about, again, picking the right folks who really have that mission embedded in them because you can't get that in a textbook. So seeing kind of like that come to fruition has been what I think, yes, defining moments for me, but what keeps me motivated to keep doing this work.
what is something that you're particularly optimistic about?
What am I something that I'm particularly optimistic about? You know, in a time where being pessimistic is just far too easy. So
Yeah, it's easy currency.
yeah.
Everybody's got their hands on that pessimism.
Yes. Something that I am really optimistic about. I will say that I think we are getting to the point where we are treating health equity as a core learning outcome. And I think we're being forced to do that by the students that we're picking. When we are picking more mission aligned students, it is really forcing medical schools and institutions and clinical learning environments to become accountable.
Mm.
You said you were about this, then you really need to be about this. And so learners are really informing how education is happening, which I think is incredible. So I think we're building these, we're helping to continue to sow into these mission aligned learners. But really, we're building also the next generation of academic medicine faculty and health professions faculty, right? So that is like a super gem that I always leave all of my learners is when you are going through these spaces, think about what it might be for you to be an instructor, a professor, a, 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 um, um, a teacher of medicine and healthcare. Because I think sometimes when you feel like something is missing, okay, then go be what you think is missing. Go bring that perspective. So I think that part is important too, because as we change the landscape of medicine, again, we have to evolve the content that we're bringing to meet patient needs. And so we're getting there. Medicine's a little slow, but I think with things like Social Mission Alliance and all of the networking and education, like innovative ideas that we get, we're starting to kind of see that become more of the standard within medical schools to where it's not going to be just this one-off elective. Like, no, this is part of our standard curriculum because this is actually how we're going to meet patient needs in our communities.
That's a really good. Okay, so that's an interesting point and a really good one. And I was about to let you go, but then you just dropped a gem, and I think it's a really important one to actually elaborate on. Do you think that, because it's something that I legitimately struggle with, I've had conversations with some folks about over the course of several years, right? Which is when you have a school like UC Davis, for instance, right, which is like a shining example of like a very specific, and you kind of talk about like, schools that are committed to social mission and that tend to attract students who know like this is what I'm about. Like this is what health equity is not going to be a caveat or an elective or like an afterthought. Like this is embedded into what we do. Do you think that I don't I think it's undoubtable the impact that that has on your students, and even just listening to you for the last 5, 10 minutes is like that's clear that that's the impact that it has on your students. But do you think that in some way that it offers a cop out to institutions who have not listed that explicitly as their mission is X. Like we social mission is what we are committed to the social mission of medical education as it should be. We're committed to addressing social and health inequities through our admissions processes and our curriculum. The schools that have not opted to do that, do you think that it runs the risk for them to say, UC Davis is doing that, right? X school is doing that. We don't have to do that. Is that something that you think is like an ancillary impact of UC Davis or schools that are committed to social mission?
Well, I would never say cop out. What I would say
I'll
is,
say
okay, you could say
it.
it. You heard that here.
Yeah.
Dr. Oyeyemi said that, not Dr. Green.
Yeah.
So I would say definitely it's an opportunity for improvement, but think about, I don't even want to say my students, our students who are mission aligned. And again, I'm into building physician leaders, right? So think about our students that we have now who are passionate advocates, and that is the future of, yes, hospital administration and those things, but AAMC, AMA, the ACGME, like all of these bodies that are rule makers. So think about our accreditation process. So again, we have to think about who has a seat at the table and who we are preparing. Like succession planning is incredibly important. Who we are preparing to be the next leaders. So to answer your question, I do think that schools that don't have as many learners who have this lens for social mission and advocacy probably don't have as much noise and pressure to move forward. It's maybe not that they don't want to, but change is very hard when we think about all of the approvals of Senate and committee and how many people have to be on board, because a lot of institutions still have a lot of folks who are not, who don't prioritize community needs and or who may have a different idea of what a social mission priority might be. So again, that has to come from the top. And so we have to, that's why I'm really big on grow our own, right? We have to grow our own leaders who get this and then send them out into the world, right? Um, so again, I think, yes, they don't have as much pressure, but I think it's starting to get to the point. It's slow moving, it's small hammer work, but all long game work is small hammer work, but definitely well worth it.
Small hammer work is a great way of putting it. Dr. Charlene Green, I really appreciate your time. We're really appreciative of you sharing your expertise, and I'm really thankful to be able to welcome you into this space. I couldn't thank you enough for your time.
Thanks for having me.